signaling in neurological conditions and mechanisms of myopia. In 2017, he was awarded £1.1 million, the Wellcome Grant for his research. This is a culmination of several previous grants that he has been awarded in the past. He supervises students at the University of Cambridge, UCL, and King's College. And he was awarded the Rising Star of the Year by the UK-based Macular Society in 2019. Without further ado, I'm sure we're all excited to hear what he has to talk about today. He's involved in so many innovative research in several aspects in ophthalmology, and we'll leave the microphone to Dr. Maru.
Great. Assalamu alaikum. Thank you very much for the very kind introduction and for the very kind invitation. The title of the talk is Retinal Function Using Advanced ERG Testing Protocols. Another title is basically ERGs are cool. There aren't many people in the world who would agree with that statement, maybe one or two, but if by the end of the talk we can increase the N number to 4 or 5, I'd be very, very happy. It's something when if you're asked what do you do, and I say I do research in electrophysiology, I can see already in the eyes of the person I'm talking to the panic, like, oh no, I'm with the most boring person in the world, I've got to get out of here quick. So it's a good way to get rid of someone as well, to talk about electrophysiology. So before going on, I just want to acknowledge first of all, Trevor Lamb is a globally recognized expert in phototransduction, photoreceptors, dark adaptation. I was fortunate to do my undergraduate project with him in 1998, 99. Then I did a PhD with him at Cambridge, and then some postdoctoral work in Australia. And I've been collaborating with him ever since, off and on. And really a lot of what I've learned about photoreceptors really starts with him. So some of the slides, a couple of the slides are from him as well. And the other person I'd like to acknowledge is John Robson, who's made lots of seminal contributions to vision science. So we all know about the Pelly-Robson contrast sensitivity measurement. So he's Robson, obviously he's Robson of the Pelly-Robson duo. And he's also done some seminal work in understanding currents in the retina and how they bring about the parts of the ERG, and I've learned a lot from him as well. So before going on, I just want to talk about levels of probing the visual system. So if I were to ask any of you, how do we see? You'd immediately say, I'm sure within a few seconds, we have photons of visible light. They photoisomerize here. Something happens at the front of the eye that most of us aren't that interested in. Very important. But then they photoisomerize visual pigment in the rods and cones, and then you have signal processing going on in the retina, and then the signal gets transmitted eventually to the brain. So there's this whole visual pathway starting with photons entering the front of the eye. But when we assess visual function in our patients, we just do it psychophysically. Can you see these letters on the chart? That's what we do. We don't really assess contrast sensitivity. Yes, we do perimetry in our patients. We don't really do dark adaptometry. But most of the things are, we're asking the patient, what can you see? Or press a button if you see this and if you don't see this. So we're basically assessing the subjective perception of vision. And that can be affected by anything happening further down or more earlier on in the pathway. And yes, we have some tricks. If you've got a certain visual field defect, it means the lesion is here or there. But we're not very good at assessing function earlier on in the visual pathway. In fact, in our clinics, we assess structure. So we've got very beautiful OCTs, multimodal retinal imaging available. So we can look at retinal structure, and we can also look at the structure of the visual pathway with neuroimaging, but it's all structure. It doesn't directly tell us, are those components functioning or not? Sometimes they go together and sometimes they don't. Sometimes structure can look completely normal, but the function is impaired. So we need ways of directly assessing function, and we do have ways. It's electrophysiology, it's just not that widely used. You can assess visual function at the level of the visual cortex with visual evoked potentials, and then at the level of the retina with the electroretinogram ERG. The EOG gives us an idea of the health of the retinal pigment epithelium, and then reflection densitometry is really a research tool. It's not used clinically at all, but you can even assess how much visual pigment there is in the photoreceptors directly. So there are ways of directly functionally assessing the electrical signaling of the retina, the health of different cell populations that are complementary to assessment of structure. And we'll talk a lot about the ERG.
The sound is just going away once you move back from this.
Sorry, okay. But probably my chair rocks, that's the problem. So try to stay close. Thanks.
Otherwise, it's very good. That's very good. Thank you.
And so this is just an example of the beautiful imaging we get on our patients in every clinic. Every retinal clinic, we get these sorts of images. But the retina, as I often say, is not just there to sit and look pretty on imaging. It's there to generate electrical signals from light that are then transmitted to the brain. So it's funny that we don't have a direct way that's so readily available for assessing that function. The other thing I want to say is, so here are some ERGs. This is the electroretinogram response to a flash delivered in the dark on the left or in the light on the right, and they look a bit different. And we tend to just measure what everyone knows about the A wave and the B wave, the amplitude and the peak time, and we might comment a little bit on the shape, but we often don't report much more than that, or we don't look at much more than that. Whereas even in these responses themselves, there are so many other features that if we're interested, we could look for. So we can get an idea of this from this component of the kinetics of phototransduction in the photoreceptors in the living human eye. This thing that's called the nose, this trough of the A wave, can tell us about flows further on in the photoreceptor. These oscillatory potentials that are commented on, but we don't really know much about them. They come from amacrine cells. They seem to go early on in diabetic retinopathy, even before we can see any retinopathy. So clearly there's something important there, but we just, no one's really looking at it. No one even knows how we should be quantifying them. This late bit that we often ignore might be affected by these currents in other parts of the photoreceptor. In the photopic ERG, again, there are lots of these other components that we don't pay much attention to, and probably we should try to quantify them rigorously using experimental protocols and looking at patients who have or don't have certain parts of their visual pathway working. And I think also with machine learning, we're going to see that there are hidden parts of these waveforms that human beings couldn't appreciate, but will probably tell us about something going on in the retina. So this is the outline of the talk. For those who aren't asleep already, we'll talk a bit about the cellular origins of the ERG components, because people find it a little bit complicated, but we'll try to make it a bit simple. And then I'll talk a bit about modeling of flash responses. So a lot of what I do is related to mathematical modeling and the work of others, mathematically modeling ERG waveforms and things that we can learn from that. That's the other thing. If I want someone to think I'm interesting, so if I want someone to know that I'm not interesting, I'll just tell them I do electrophysiology. Otherwise, you should see faces when they ask me, what do? I say, I work in modeling, and then immediately the face changes. What sort of modeling do you do? Marks and Spencer's ugly collection, what is it? And I say, no, mathematical modeling of electrophysiology. And so, yes, I see you're the type of person who do that. So we'll talk a bit about modeling of flash responses. Can we extract parameters, phototransduction? We thought we could, now it's become a bit more complicated. And then I'll talk a bit about dynamic assessment of light and dark adaptation using the ERG. So can we develop protocols where, so ERG's the standard way of doing them is you put someone in the dark until he's fully adapted, and then you deliver some stimuli, so he's in a steady state, and then you take him or her to the light, and then wait till they're fully adapted, and then deliver some stimuli. Whereas what we miss is the dynamic changes between light and dark. And sometimes it's what our patients talk about. Their vision's okay once they've got used to a certain light level, but they say they have problems moving between different light levels, and we're not very good at quantifying that. And could we get better? So I might talk a little bit about that, and the things it can even tell us about basic retinal adaptation, light and dark adaptation. So cellular origins of the ERG. So this is an OCT. We're all happy with OCTs, much happier than with ERGs, most of us. And we have the inner retina and the outer retina. So the outer retina has the photoreceptors that are there. They signal to bipolar cells. They signal to ganglion cells. Photoreceptors, obviously, we know are the cells that respond directly to light. Do they, maybe say on the chat, tell me, do they depolarize or hyperpolarize? So you may remember, you probably don't remember from medical school, every membrane has this negative potential, and that potential can become less negative, so it becomes more positive, that's called depolarizing, or it can become more negative, which is hyperpolarizing. What do our photoreceptors do? Does anyone want to hazard a guess? You'd be 50-50, depolarize or hyperpolarize, or you don't have to. Has anyone said anything? Because I can't see the chat.
Yes, I got Faisal Al-Marik. He said hyper.
Oh, very good.
Yeah.
Good.
So,
And
yeah.
excellent. So you guys are already ahead of the game. So yeah, I was hoping.
Here.
Sorry?
We've
Yes.
got a winner here. Yes.
Yes, the winner, absolutely. We don't have a prize, unfortunately, but kudos. So a lot of people, when you ask them, they say depolarize. And even if I talk to people fresh out of medical school, because we all know that excitable cells, they depolarize in response to a stimulus. That's what neurons do. They depolarize in response to the stimulus. Weirdly, photoreceptors hyperpolarize. No one quite knows why they seem to go the other way. And it could be, as some people have said, that we've got the stimulus the wrong way around. We're thinking about light, but maybe what the visual system is interested in is dark. So you look at this slide, look at the top of the slide, pointer, you're interested in the dark against the white background. If you're a frog and you're looking at the sky, you're interested in this dark fly against the bright background. Predators often don't glow, they're something darker than the surrounding. So you could say that the photoreceptors are there to detect dark, the stimulus is dark, and they do depolarize in response to dark because light is the natural condition. So anyway, that's a bit philosophical, but it's interesting, isn't it? So that might be why they hyperpolarize, who knows? So photoreceptors hyperpolarize, it's like they turn off with respect to light because they become more negative. Or you could say they depolarize in response to the offset. Right? But anyway, they're off cells, they get more negative. And bipolar cells, as you know, many of them depolarize. You have on, and you have some off bipolar cells as well. So that complicates things a bit. So immediately we're now able to kind of in a crude way, understand what happens when you deliver a flash of light and you get this waveform. That's a schematic waveform here, but we have this negative bit first where it goes down and then it goes up. Clearly, and I won't ask again on the chat because you will get it right anyway, that the negative bit is the photoreceptors hyperpolarizing, largely, brackets also bipolar cells contributing there as well. And then the second bit is the on bipolar cells largely depolarizing. So it's very kind of easy to understand. As long as you know up from down, you can tell up from down, you can interpret ERGs. And now we can now localize pathology. If someone's got a problem in their inner retina, in their bipolar cells, then they'll have a normal A wave, but they'll have a much diminished B wave, this positive bit, and they have what's called an electronegative ERG. If someone's got a problem with their photoreceptors, the A wave will be reduced, and the B wave as a consequence, because they get their signals from the photoreceptor. So you can now localize pathology. You can wait until someone's dark adapted, deliver it in the dark, and deliver the flash in the dark, and you get an idea of the rod system function. Deliver it in the light, you get cone system function. And then the other stimulus that we use as a standard is a 30 hertz flickering light. So 30 times a second, it's flickering, and that's too fast for the rods to respond to. And it's also delivered on a background that saturates the rods anyway. So it's a sensitive way of looking at cone-driven function. So these are our standard ICEV ERGs. Normally, the patient gets dark adapted for a long time, delivers a dim. We deliver a dim flash. We get a B wave. Where's the A wave? I hear you ask. Can't hear anyone asking anyway, but where is the A wave? It's because it's so small. There's amplification in the pathway, so you don't really, that B wave couldn't have come about if there wasn't a rod photoreceptor response, but you just can't see it because it's too small. But when you deliver a bright flash, you see a nice A wave and a B wave and these little things called oscillatory potential. And then in the light, the patient adapts for 10 minutes to a light background, and then you deliver a flickering light and then a flash of light as well, and you get an A wave and a B wave here. Other stuff don't look at, but might be quite interesting. So,
Omar, I think your voice is still fluctuating. So if you can just keep the same distance from the microphone, please.
If I may, actually, I think it's maybe the network. I'm gonna switch off the video from your side just for a bit. Maybe it will help this issue. Okay.
Okay, yeah, it could be the network as well. Sometimes we'll have some problems with the network. So ICEV is the International Society for the Clinical Electrophysiology of Vision, and they set the minimum standards in electrophysiology so that labs across the world can compare, because they're delivering the same sort of stimuli, although they have their own normative data, and you can have hours of fun looking at the ICEV website and see what the standards are. And it helps, it kind of gives you a lingua franca across the world, because everyone knows what the ICEV standards are. So if you've done those on your patients, we kind of know what we're looking at, although you may well have done other things as well. So this is just to remind me of how important ICEF standards are. This is me a while ago when I had more hair. This was some years ago, where there's a link between St. Thomas's Hospital and an academic eye department in Tanzania. And as part of that link, the Tanzanian department had been given an ERG device from a Japanese eye department. And because I know about ERGs, I was basically sent there to do that and do some other things, teaching and other things, but also to set up the ERGs. And you may not be able to see from this picture, but you can see from this picture that when I got there, so I've flown all the way to Tanzania, the manual is in Japanese. And I don't speak Japanese, and this is before the days of Google Translate. So I thought, crumbs, what am I going to do? I've flown all this way. But then the numbers were there. I was going to say English numbers, Arabic numerals, aren't they? And then I could work out what the ICEF stimuli were. So we got it working. I don't know how useful it was, but we got it working. And then we did some other research while we were there and a lot of teaching. So it wasn't a wasted visit. Then going beyond ICEV, beyond standard stimuli, this is just how we can think a little bit about how we kind of build up an ERG. If we start with very dim flashes that are at the bottom, there it is, we're delivering very dim flashes, we get this very kind of late component that's negative and then positive and then negative. And that has been shown to come from ganglion cells, so really far in the inner retina. And it's very hard to record this actually from humans. And then when we deliver a brighter flash, we start getting a signal. We see it in the B wave, and that's from the rod bipolar cells, the schematic of the retina on the right. And then you deliver a brighter flash still, you start seeing the A wave. So the photoreceptors obviously were responding all the way through, but it's because there's so much convergence in the pathway that lots of photoreceptors converging on a single bipolar cell, lots of bipolar cells converging on a ganglion cell. So you really, for the dimmer stimuli, you see the ganglion cell response first, then less dim, then you start seeing the bipolar cell response, and then later you see the photoreceptor. So you could turn it on its side in a way, and if you think about it that way, that's how the visual signal is processed in the retina, and it's that order in the ERG. So the very latest components here come from the ganglion cells, and the earlier components come from the bipolar cells, and earlier still you get the A wave, this thing I'll talk about later. Even there are certain things in the ERG called the early receptor potential right at the start that you can't normally see because of the artifact. It's probably related to photoisomerization of the visual pigment that's in the membrane. So if you know, we said if you know up from down, that's good. If you know left from right, that's also helpful in interpreting ERGs because then you get an idea of where these signals are coming from. Okay, so here's a little question to wake you up. Here's a patient, an OCT from a patient. Yes, we're happy with OCTs. What's wrong with that OCT? Anything wrong? Is it normal? Maybe you can read the chat if anyone wants to hazard a guess, or maybe no one has. Nothing on the chat. So that OCT is completely normal? Okay, now 3 things have appeared, but I can't see them. Has anyone?
Yeah. Side, it says cavitation, loss of EZ, Victor IZ.
Okay. Abdurrahman Saidi, good to hear from you. So that's a good thought, that it's true, and it may be that this is just a bad scan, but I do accept that if this was a young patient, we'd expect this to be very crisp, and it's not so crisp. There's something else, and it's because we're all retinal specialists, we don't see this. Anyone else?
So Dr. Noulati said loss of the interdigitation zone.
Okay, so that's, and I think because I know what it is, I'm kind of, it's a bit unfair. So you're absolutely right that this isn't very clear, and so, but I think that's probably the quality of the scan more than anything else, because everything's a little bit fuzzy. Anything else?
The OPL more hyper-reflective in one side than another?
Yeah, that's a good point. It could be related to a tilt in the scan. Sometimes you see Henle's layer a bit more and that can be normal. So it's because we're all retinal specialists. Is there a glaucoma specialist in the room? Is it because who's come in by mistake? They came to the wrong room.
We can look in the list and name them out. But
yeah. So there's a big thing here that's missing, which is the retinal nerve fiber layer. So I've written right eye here, but if I asked you and I hadn't written right eye, what eye that is, you might be a bit hard pushed to say which eye, because normally there should be something very hyper reflective here, which is the retinal nerve fiber layer, and then a ganglion cell layer on the nasal side of the OCT. If you look at the left eye, it's completely perfect. So this patient's quite interesting. So very sadly, she lost vision completely in her right eye due to something that was either inflammatory or ischemic. No one got to the bottom of it. Maybe inflammatory led to something ischemic. And her optic, her ganglion cells just vanished. She had developed optic atrophy, complete optic atrophy in one eye, which is NPL, and the other eye, fortunately, thankfully, remains many years later completely normal. And that's just a ganglion cell, you know, a nerve fiber layer scan showing that there's nothing there, data not available because it's actually down there, whereas in the left eye, it's completely normal. And this sort of patient, fortunately, her left eye is good, but it's very useful for us to probe what are the ganglion cell components for the ERG, because when do you get a patient who's completely normal in one eye, a control eye, and the other eye's completely lost ganglion cells? Normally that's in sort of in vivo animal experiments where people block ganglion cells or poison the ganglion cells, but you can't obviously do that in a human being. But you do get the odd patient like this who is kind of gold dust. And when we look at the ERG here from her right eye and left eye, we see that the A wave and the B wave are very similar. And it's this later bit where she's lacking something in that affected right eye. It's the right eye is a bit raised, elevated compared to the left eye. So there's this component here called the photopic negative response that, you know, some people are these guys making it up? Actually, they're not making it up. There really is something here that comes from ganglion cells and might be interesting to look at. So people are looking at it, but unfortunately it's such a small component so late in the ERG that whether this is going to be any use or not, I really don't know. People wondered about it. It could help us in glaucoma because you can detect ganglion cell dysfunction before it's lost on the OCT, and I'm not really sure it's very good at doing that, but it's interesting. So you can, if you look closely, you can even get signals from the ganglion cells in the ERG. So now we'll go on to a little bit about the modeling of flash responses that's been done over the last few decades and how that came about. So this is a cartoon of a photoreceptor, and as we all know, in the outer segment of the photoreceptor you have these outer segment discs, and that's where you have the machinery of phototransduction. And this is what happens. I don't have to remind you, I'm sure, but just in case. This is your membrane. This is your cyclic nucleotide gated channel, CNG channel. So mutations in subunits of that channel might give you retinitis pigmentosa or achromatopsia, cone subunits. So sodium and calcium are coming into the photoreceptor outer segment, depolarizing the photoreceptor, a photon, and that's being held open by cyclic GMP. That's why it's called a cyclic nucleotide gated channel, because it's gated by this thing called cyclic GMP. And the phototransduction cascade happens. Light isomerizes rhodopsin. I've called that R star, activated rhodopsin. Rhodopsin activates lots of G proteins. G protein transducin then activates phosphodiesterase, and then the phosphodiesterase hydrolyzes the cyclic GMP, and that's why if you're measuring a photoreceptor current, as people have done suction pipette recordings, you'll see the current fall in response to light, and then various things happen to bring the response back, which I won't go into. But this activation phase of phototransduction, one can model, and Trevor Lamb and Ed Pugh back in 1992 painstakingly modeled. So it was a seminal paper. They went through every stage in the activation phase of phototransduction and tried to model what the kinetics should look like from what we know biochemically. And so this is a very kind of crude version of it. But if you imagine a flash of light, that will immediately activate a whole load of rhodopsins, and it'll be like a ramp, not a ramp, sorry, it'll be like a step in time. So it's like a pulse of light, then you get a step. Each rhodopsin that's activated activates multiple G proteins. So the rhodopsin is diffusing and activating a G protein here and a G protein there and a G protein there. So if you were to think what would happen to the concentration of activated transducin with time, it'll be a ramp. And then each G protein activates only one phosphodiesterase. So it's a ramp again for phosphodiesterase, and some of them won't ever meet a phosphodiesterase. So you get a lower gradient. And then the phosphodiesterase chews up lots of cyclic GMP. So then you get something in T squared. So this may not be relevant to many of you, but if anyone's remembers their mathematics, this is mathematical integration. So you have a pulse of light, you integrate a pulse, you get a step, you integrate a step, you get a ramp, and you integrate a ramp, you get T squared, something in X squared. So it's quite interesting that the activation phase of phototransduction proceeds like that. And they ended up, after many equations, they ended up with one kind of summary equation that showed how the circulating current should drop in response to a flash of light that caused this number of photoisomerization. So don't worry about knowing the equations. It's just to give you a flavor of how you can really dissect things potentially from the ERG. So one equation, and when you fitted lots of suction pipette recordings of circulating current in response to lots of different flashes, this equation fitted all of them. So it was really quite a step forward. This, as you just changed phi for whatever the intensity of the flash was, and you found the equation fitted. And then afterwards, people started applying it to the ERG, and it seemed to be very successful for some years. And then we now know it's actually limited. But I'll just show you how we did that. So and how others have done that. So these are responses to flashes of different intensity delivered at time 0 in the dark. And the first thing we know about this, the responses in the dark, we know that the rods and the cones are responding. So you have to do something clever where you deliver the same flashes in the light on a blue background that saturates the rods but doesn't desensitize the cones, and you get these responses. And then if you subtract those responses from those responses, you can get an idea of the rod isolated response. So these are the responses from the rod photoreceptors without the cone bit, we think. And amazingly, you apply the model to it, and one equation fits all of those responses. So that was quite impressive to me and to a number of people. So it's been used for decades to model the A wave of the ERG with some success, but as we'll see in a few minutes, actually some of that fit was fortuitous and there are other things going on. And then one thing we did some years ago is we thought, well, actually, if that's the response to a flash of light, what if you had not a flash of light, but a step of light? So the background turns on and doesn't go off. So not a flash, not a pulse, but a step. It turns out if you go through the mathematics, then it's just you integrate everything again. So you get a term in t cubed rather than t squared. And those same parameters fit perfectly. It doesn't fit down here because it's only the activation phase of the response, not the recovery. But this bit fits perfectly with exactly the same parameters. So that was quite powerful and interesting. You know, you can get parameters of phototransduction without having to take somebody's eye out, a patient's eye, and put electrodes into it. No, from the ERG, you can get an idea of what the amplification constant of phototransduction is potentially in their photoreceptors. And it was being used in 2002 when they found that transducin translocates hugely from the outer segment to the inner segment. One of the ways they showed that was a change in this amplification constant. We looked for it in human beings and found that we didn't see that. So I think it translocates probably a lot quicker in human beings than in mice, perhaps. And then the caveat I was talking about was shown that the A wave isn't just shaped by the outer segment current, it's also shaped by currents in the photoreceptor inner segment and the axon, probably. So the first sort of hint that the A wave isn't really just the circulating current is when you look at, this is experiments in macaques, monkeys, where that's the ERG that we know, the A wave and the B wave responds to different flashes. They injected something to block transmission to bipolar cells, and they found that, yes, you lost the B wave, but you still got this early recovery. Up until this time, everyone was saying, oh, that's the bipolar cell contribution coming in. That's why the A wave does this thing that people are now calling the nose. But it can't be, because you've blocked the transmission to bipolar cells and still you have this recovery up until it then plateaus. You take patients with complete CSNB, where again, you've got blockage of transmission from photoreceptors to the on-bipolar cells, blockage of on-bipolar cell signals, and they have the same thing happening. These are some, and we found that in our patients as well, but these are some recordings from a long time ago, again, showing you don't lose all of the B wave, you still get this early recovery, which people call the nose, and then it plateaus out. So it means this bit isn't coming from the bipolar cells, it's coming from the photoreceptors, which is interesting. And then this is just a patient of mine who had, unfortunately, a while ago, a central retinal artery occlusion in one eye, which was represented by the black trace. And we know that a central retinal artery occlusion will kill all your inner retina, but your photoreceptors will respond normally. So isolating his rod responses in the same way I mentioned, you subtract out the cone responses, you see the same thing. His normal eye, you get an A wave and a B wave, and the eye with the CRAO, you don't just get it going down and not recovering, it comes up again. So that must be coming from the photoreceptors, not from the bipolar cells. and Robson and Frischman wrote a seminal review article in 2014, and suddenly it got hugely more complicated. So they modeled, everyone had just been concentrating on the outer segment, and they modeled all of the current flows in the photoreceptor. So now this becomes quite unwieldy for me anyway. And they developed a model that, and this is some of my research participants, their recordings, rod isolated A wave. And when you fit the model, it really fits well, even including this bit where the A wave recovers, and then it doesn't fit over here because that's the B wave coming in and bipolar cell. So this is a sort of step forward, and it's helped us understand waveforms in complete CSNB. And there's something else which I won't talk about because you're probably already bored with this modeling part of the talk. KCNV2 retinopathy, a very interesting condition where we aren't quite sure what this KCNV2 protein is doing. They interestingly seem to lose this nose. So it really is something going on in the photoreceptor inner segment or further on that changes in those patients. So their ERGs look quite unique. Right, so I'll now move on a little bit to talking about how, just examples of how you can use the ERG to assess adaptation, look at light and dark adaptation. And we used it in the past to look at how quickly cone photoreceptors can recover following intense bleaching exposure. So these experiments are often done on myself or Trevor Lamb or other unfortunate research students in the lab. And we'd be blasting our eyes with very, very intense light, and then seeing how quickly did the cone circulating current recover in the photoreceptors afterwards. Because we know from previous work, rods take ages to recover, 10, 20 minutes, 30 minutes, 40 minutes to recover fully from an intense bleach. How quickly does the cone circulating current recover? And these were a couple of papers from a while ago, and I won't go through all the details, but we by delivering very bright flashes within milliseconds following extinction of a bleaching exposure, we found that it looked like our circulating current was back to the dark adapted level within seconds. So the current in the photoreceptor recovers very quickly, but the pigment still takes several minutes to recover, but the circulating current recovers quickly. And this is thousands of times faster than rods. And it probably explains why the cone responses are fine in most patients, or many patients with vitamin A deficiency or RDH5 retinopathy, fundus albupuntatus, because cones can have a lot of their pigment in the bleach state, but still have a fine circulating current. Whereas in rods, if you have lots of ops in there, it shuts off their circulating current. So anyway, it's again to give you a flavor of how you can assess things at the level of the photoreceptor through the ERG. At the level of the photoreceptor outer segment, you don't need to necessarily understand everything I'm saying, so don't worry. I'm not sure I do myself anyway. The other thing we looked at was to look at whether we can use the ERG to look at cone photopigment regeneration. So we know that light isomerizes 11-cis retinal, and then it has to go all the way through the RPE, or for cones, Muller cells as well can be involved, until it comes back to 11-cis retinal. So there's this long, relatively long pathway it has to go through before it comes back to 11-cis retinal. And again, this is just to give you a flavor of how we approach that problem. This is a response to a dim flash delivered on a blue background. So there's no rod component here. This is all from the cones, cone bipolar cells, cone photoreceptors on the dim blue background in a normal state. And then the eye was exposed to intense light for 40 seconds. And then as soon as the light was switched off, this is what the response to that same flash looked like. And then if you deliver that same flash many times as time goes on in the dark, you see it finally recovers back to the dark adapted level. And we could measure these amplitudes of the responses and plot it as a function of post-bleach time, so time in the dark, and that's shown here. So that's the responses in the dark. Then the bleach was given, and then as soon as the bleach finished, the response is very much reduced, and then it recovers with time. This is many experiments that were averaged. And then we can also, so why is it down? And I won't go through all the assumptions and why we think they're valid. We thought the reason that the response is down is basically for cones. It's because you have, say you've had a 90% bleach, you've only got 10% of the pigment left. So the flash is 10% as bright. So it's as if you're delivering a very dim flash after the bleach, and as pigment recovers, the flash intensity goes back to what it really is. If that's the case, then these responses should look identical in form to flashes of of lower intensity that are delivered in the dark. And these are dimmer flashes, and they're the same form. So it suggests that what we thought was the case was actually the case. So it's consistent with the notion that the responses are reduced just because of the amount of pigment that's been bleached. So you've got less pigment unbleached there. Don't worry if you're not following. I'll get to something in a few slides that just kind of brings it all together. But the way we then approached this was, okay, if in the dark you deliver flashes of different intensity, and then you can measure those amplitudes and plot them as a function of flash strength here. So that's a flash of the intensity that we were, intensity F that we were looking at. A flash of half that intensity gives you a reduced response, not half the response. It's not linear, so we have to know about that. And then after the bleach, so we make a function there. Then after the bleach, we deliver flashes of fixed strength, but because they look less intense because there's less pigment there, we can measure those responses again and then kind of back calculate and work out how much pigment was there present at the time that each flash was delivered. And we did that, and we do that transformation. It kind of looks the same, I know, but it is a bit different. And now what we think we have here is an estimate of cone photopigment regenerating in that living human eye. Then we looked at what sort of kinetics does this have? So all the people in the past, or most of them, had fitted recovery with a single exponential. So again, this is really for the people who are into maths, a first order process where the rate of regeneration is proportional to how much you've got that's unregenerated. So it's an exponential. But we also explored fitting it with this rate limited model where you have an early linear rate. So it's a constant rate, and then it becomes an exponential. So those are the differences. So after different bleaches, a rate limited model will look like that, an exponential model will look like that. And to cut a long story short, let's just go through this, because even though I can't hear you, I can feel you must be getting bored, and there's something else I want to talk about. We found that after lots of bleaches, you had that same linear rate of recovery. So it really suggested that regeneration kinetics are rate limited and not exponential. And these are just responses from me and Trevor many years ago to different bleaches. They shifted a bit, but they all have the same initial rate of recovery. We then tried to fit previous data with the exponential model or our model. Our model fit a lot better. We looked at densitometry data, that's directly measuring pigment in an eye. And from previous publications, they tried to fit it with single exponentials, didn't fit very well. We used our model, it fitted really well. I love this slide, it looks beautiful, doesn't it? A line going through the points. We found, interestingly, that the rate was slightly slower than what we were finding. Then we did some crazy experiments where we exposed our eyes to very bright intensity, and then found that again, it fits this rate limited model better, but we found that, yes, the rate was indeed slower. Which was interesting. And this is densitometry data from decades ago, and this is our ERG data, and it really fitted very, very well. So we thought that it really is possible from the ERG to get an idea of cone photopigment regeneration kinetics, which is interesting. And it's going to be interesting to look at diseases where it's thought that cone dark adaptation is normal, and see, is it really normal? Is pigment regeneration normal? Because I suspect it'll be slowed. So that's that. I'll move on just quickly now to talk about looking at light and dark adaptation of the rod system, because what I worked out quite soon was when I tried to do what we'd done in normals in our cells in patients, it was very difficult. No one could take those bright intensities. So we're working on trying to make it easier for patients to tolerate before we can really take that to patients. But what they can tolerate much more easily is the dim flashes that are needed to look at rod dark adaptation. So I will these are responses to very dim flashes where you're getting responses from the rod-driven bipolar cells. That's work we did a while ago. And what I'll do is I'll just go through these because I want to leave some time for questions as well. You asked me to start my video, is that right?
Yes. Yeah, it seems like, yeah.
Okay, so this is so the rod system is very different from the cone system. The reason that rod sensitivity is so low after a bleach isn't because you've just got 10% unbleached pigment. It's because all of the bleached pigment is saturating the rods and shutting off the current. That doesn't happen in cones. So it's a bit subtle, I know, and maybe you don't understand what I'm talking about. That's okay. But just to say, rod dark adaptation is qualitatively very different from cone dark adaptation. But you can still look at it, and we did look at what happens in the rod system is if you deliver the same flash on different backgrounds, you see that the peak becomes earlier, the peak of the response, and the response becomes smaller. And after a bleach, you get the same thing. The peak is earlier, the response is smaller, and then with time, it recovers to the dark adapted level. So it's telling us that for the rod system, it's as if there's a background on when you switch the light off, something that's like an equivalent background, and that decays with time. And that's how our rods and our rod bipolar cells then recover. And then we did lots of complex stuff with that, Crawford transform to look at that. And just to show that you can get estimates of pigment regeneration and apply it again to densitometry data, and the same model fits, but just different parameters for the rods and for the cones. So that was quite cool. And then this is some work that might be a bit more relevant to people clinically, a tiny bit, probably not much. So this is a slide from, I've got a bright PhD student. I'm fortunate to have Xiaofan Zhang, and this is what we're trying to develop at the moment, is an ERG protocol to look at how the rod system adapts to the dark. So you keep them in the standard ICEV background for some extra time, and then you deliver a dim flash every few minutes, several flashes in the dark, and then you watch that response recover with time after the end of the background, and you get this kind of recovery. The math is very complicated, so I won't tell you what these curves are. But this is a whole load of normal subjects, and that's an older subject who's 82, and you can see that they're a little bit slower than the others. And this is a subject. The red responses are a subject with Sorsby fundus dystrophy, mutations in a gene called TIMP3. We know they have thickening of Brooks membrane, and they have slower dark adaptation. And now we're able to show that nicely with the ERG. And the blue symbols are a patient with vitamin A deficiency, showing the same thing, slow dark adaptation, mild vitamin A deficiency. We were fortunate to see her at an intermediate level, because when she was completely deficient, it didn't recover at all. But when she was mildly deficient, it looked like that. And when she was back to normal vitamin A levels, it was these blue symbols here. So again, this is extra evidence that Sorsby fundus dystrophy is very much like an ocular version of vitamin A deficiency. The vitamin A levels in the retina are not high because of what's happening in that disease process. And in fact, electrophysiologically, the recovery can look the same. So that's quite interesting, and we're trying to take that further, because this is something we can do in patients where the cone recoveries weren't so easy. I just want to finish with something that again is a bit more clinically relevant. You may have come across this, you probably may not have, this phenomenon of transient smartphone blindness, and we kind of clinched what was going on using the same sort of ERG protocol. So this was a couple of patients who presented with just loss of vision in one eye occurring at night in one patient before she went to sleep. Another patient was when she got up in the morning, she found she couldn't see out of one eye, but she could see out of the other eye. So that's very weird. And then over the course of 20 minutes, the eyes equalized. The lady who was before she went to sleep, then she said, well, when she got up in the morning, it was fine, but they couldn't work out what was happening, and they sought attention, and they were investigated for TIAs. One person had MR angiography, lots of kind of invasive, non-invasive investigations. One patient was started on a blood thinning agent. They thought they must be having some sort of transient ischemic episodes, but they're weird, right? Every night, most nights, you lose vision in one eye, then it comes back. It's kind of strange. One of them was in their 20s, so unusual to get ischemic episodes at that time. Then they saw a colleague of mine, Gordon Planter, a very eminent and intelligent neuro-ophthalmologist, and he took a history, right? It's something we tend not to do much. In retina, we just get the imaging, and then we look at the EZ line, and then later we kind of introduce ourselves to the patient. But he took history. He said, what happens when you lose vision? Nothing. I'm just going to sleep and I lose vision in one eye. Okay, but what are you doing? And it turned out that all they were doing was, as we all do, okay, surfing the net on their phone or viewing something on their smartphone. And it just so happened that they were lying in bed so that one eye's covered by a pillow, as happens, and they're on their sides, and so they're viewing it with one eye. So they're in the dark room. This is dark adapting because it's covered, and this eye is light adapting because it's viewing the smartphone. And then when they look around in the room, they suddenly realize, I can see out of this eye and I can't see out of that eye, and that's very weird. We all know when we're in a light environment, we go into the dark, it takes a while before we can see, but that never happens in one eye, right? If it happens in one eye, then you're worried, and they were right to be worried. It's a weird thing to happen. And they didn't believe him first when he said this could be what it is. He said, okay, try lying on the other side, see what happens. Yes, it reversed. Try viewing with both eyes so that you don't have one eye covered. Yes, it didn't happen. And it turned out that that's all it was. It was this what we then call transient smartphone blindness. And people still didn't necessarily, the patients didn't believe us, other people didn't believe us, that could this really happen? Even when we published this, people were saying, well, we're not really sure. And obviously you need to get a proper history that it does recover with time, otherwise maybe you do need to investigate your patients. But we showed nicely with the ERG, I did these ERGs on myself, as you do. I just viewed a smartphone for 20 minutes in the dark with the one eye covered, and then delivered those same dim flashes straight after that exposure in the dark. And you can see the B wave from the eye that's been covered is very big, and the B wave from the eye that's viewing the smartphone is small, and then over time we showed it recovered. So this localized bleaching from a smartphone is enough to reduce your signals demonstrably at the level of your rod bipolar cells. So that was quite cool, and we thought it's important to let people know about this, so that patients, once you get the right history, some patients have this history, but you need to investigate them because you're not absolutely sure it is the smartphone. But once you get this history and you know it recovers with the time you'd expect, then you can avoid lots of expensive or invasive investigations, stop changing their medication. I've had patients email me, or a patient emailed me saying she elegantly described the same phenomenon and said, I think this is what it is, but my doctor wants to change all my medication because he thinks I'm having some problem. She was on medication for another disorder, and I sent her the paper. I said, yes, I think this is what it is. So it just shows that ERGs can be useful, and this is just showing the recovery in the dark. Unfortunately, the media went berserk. They thought, okay, so you're saying smartphones cause blindness. They latched onto this smartphone blindness story, and we had to keep reassuring them, no, it's completely benign. It's nothing. There's nothing wrong with this. We were actually trying to reassure people. And my wife was contacted by an acquaintance saying, oh, my kids won't stop, being on their tablets before they sleep, and remember your husband's study that showed it causes cancer. Can you just tell me about that? Again, it doesn't cause cancer. There's nothing that we know. It's not a harmful phenomenon as far as we know. I'm not encouraging people. It probably will mess up your sleep if you surf the net or view a tablet before you sleep, but we don't know of it as something harmful. We even had, I don't have the slide, we even had a Channel 4 British TV program wanting to investigate this phenomenon. So I had a TV presenter come and get their own ERGs done in our lab in St. Thomas's Hospital. And that was probably, as I say, one of the few times in the history of the universe that ERGs have been on primetime television, as it was at that time a few years ago. Good. Okay, so now we're coming to the end of the talk. You'll be happy to know it was a kind of whistle-stop tour, which a lot of it may have been a bit subtle to understand, and I know I speak very fast. But I just want to say that electroretinography is important in many situations clinically. Not every patient needs electroretinography, but often it can give us some information that's complementary to imaging. And using these advanced non-standard techniques can really give us information about physiological and pathophysiological mechanisms in various inherited retinal diseases and other diseases. And also stuff I haven't talked about, but I am looking at, is the ERG can help us even understand neurological disease. There's a lot that's happening in the retina that's similar to what's happening in the brain in many neurological syndromes, and certain changes in the ERG might give us insight into those diseases. And also, as a complete another talk, looking into what's driving myopia, because we know it's driven from the retina. I'm looking at associations between sort of myopia polymorphisms and potential changes in the ERG. So thank you very much. That's just to show that there's so much more in the ERG than we normally look at. And I'm hoping that like at least one or two other people now agree with me that ERGs are cool. So that you'll be happy to know that that's the end of the talk. And I'm even happier because it's the end of the fast now here in London. So I'll break my fast as well.
MashaAllah.
Questions?
Omar, thank you ever so much for this interesting presentation. I mean, since I arrived from London here, all the curves I've been hearing about were basically flattening the curve and staying at home and avoid the, increasing the steepness of the COVID curve and so on. So this is a breath of fresh air actually to hear about different curves. I mean, it's quite fascinating, and I think you are one of the very, very few people in the world who can actually look at the retina and let it talk to him, so to speak. I mean, you are basically in a position where, you know, as you just showed, the phototransduction cascade, most of the proteins there actually are encoded by genes that we already know of, and several steps that can go wrong actually can give you pretty much, how they say it, like, you know, characteristic way of what the retina shows you, and it can even help explaining to patients, because patients come with a myriad of symptoms. So when people speak about night blindness, everybody has got a different way of expressing themselves, and sometimes people are talking about difficulty in adapting to dark rather than being night blind and so on. And electrophysiology helps put things in context both for the clinician and for the patient as well. So I think what you're doing is fascinating, and actually you are one of the pioneers of translational research, where you take this, you know, straight from the lab and you apply it clinically. So I can't be more grateful for people like yourself being around and talking to us.
Thanks, that's very kind. And just to say, I mean, and you're an expert on inherited retinal disease, as you know, and you and I, we both see patients who we think we've solved their problem because we found the gene, and then they still say, but why can't I see it? And we're like, well, actually, I still don't know why. We know what the genetic cause is, and as you say, the ERG in some cases will then help us explain, okay, that's the reason you can't see, and then still, of course, we need to develop a treatment, of course.
So thank you very much. And there is, I have this question which sometimes kind of bothers me. When you talk about the rods actually saturating, and then we know that patients with achromatopsia behave slightly different from people with sort of like, as they grow up, they develop sort of like a cone dystrophy, for example. The achromats are sort of kind of got used to it, and they do have some sort of level of useful vision to navigate and so on. While, you know, I don't like to use the old term hemeralochia, but those patients with cone dystrophy are more sort of blind in good lighting conditions. So can you elaborate why the rods don't seem to, you know, I mean, why those patients are with cone dystrophy are more bothered than those with achromatopsia, I think?
So I think there could be lots of reasons. I'm sure you'll have some good ideas as well. I think part of it is that the achromats have been there from like that from near birth or birth, so they've sort of adapted to it. Whereas a cone dystrophy patient, the cones are dysfunctional with time. The things that they were used to doing, they now can't do, or they're finding more difficulty. So that might be one of the reasons. Some of the achromats are very photophobic as well. So I think there's a spectrum there. Achromatopsia itself is interesting, slight tangent probably from your question, in that there does seem to be some rod function when they should be saturated. So in animal studies, it has been now shown that the rods seem to be able to work at much higher intensities, background intensities, than it should be the case. They should be completely saturated, and it could be partly because their pigment's so bleached, so every flash looks dimmer to them, and maybe many of their phototransduction proteins have moved from the outer segment to the inner segment. So that means that suddenly the outer segment has escaped from saturation. So that might be a reason why they have these responses. It's been shown in animal models, and I think it is in patients as well, because there are at levels, I sometimes talk to the patient while we're doing the ERGs, and where we get no response because they're achromats, and it's a flat ERG, and the rods should be saturated. But I ask, can you see the flash? And he says, yes. So he's there. You can't get an ERG, but their rods, because they haven't got any cones that are functional, are somehow responding, and it's something we don't fully know. That might not have been a direct answer to your question, but it's
no, it's actually a good answer there, because like I was thinking it might have something to do with the rod cone interaction. So as you switch from scotopic through mesopic to photopic conditions, actually there is some sort of inhibition of the rods that is exerted by the cones as you switch to photopic vision. But then probably this sort of inhibition, when it's not there, probably you are somehow, how they say it, you know, kind of making the threshold for rod saturation slightly higher so that you can have a bit of leeway to see in the, and that's just my simplistic understanding of the phenomenon.
Yeah.
We have, sorry, go ahead.
Yeah, no, go on. Yes, go on.
No, I'm just commenting. So we have a question from Shada Al-Frehi, and her question is, how useful are handheld ERGs from a clinical standpoint?
Oh yeah, that's quite close to my heart as well. So there's this, I many companies, just to say that first, but there's this Retinal device, which is quite a popular handheld ERG. I think it's very cool and can be useful in certain circumstances, but in most cases, it's still not as good as a traditional ERG setup. But I think it's great. You can use it in clinic. And for example, what I use it, and will be aware, is sometimes where there are patients where it's helpful to know about their generalized cone function, and you can get that in clinic straight away with this handheld device, deliver a sort of full field ERG. It just sort of sits over the eye, and they're in a light adapted environment. You can get an idea of their cone function. You get a flicker ERG and a flash ERG. And for example, in patients with Stargardt's disease, ABCA4 retinopathy, where we know that if the generalized cone ERG is affected, that's a bad prognostic sign. Whereas if it's intact, it generally means that your patient's likely to preserve their peripheral vision, which is still very important for the long term. We found that we can actually, rather than we send these patients for conventional ERGs, but we can tell in clinic now, we've done it on over 100 Stargardt's patients, we can tell which ones have cone dysfunction and which ones don't. So you can actually tell them in clinic within a few minutes, rather than getting them to come on another day for something that takes an hour. So I think in some respects it can be helpful, and I use it as a research tool as well when we want to get ERGs from large numbers of participants. So I do research with the Twins UK cohort at St Thomas's Hospital in London, and we've done handheld ERGs on sort of 1,500 or more, because we can do it very quickly. They come for lots of research studies, and we just do a handheld ERG at the same time. However, often it's used with skin electrodes, which means that the signal to noise ratio is very much diminished. So I often find the flash ERGs are a bit noisy, though if you do it carefully, you can probably get a good flash ERG. And we've also shown that it's very dependent on where you put the electrode. If you put the electrode just a little bit further from the eye, the skin electrode, which is more comfortable, the amplitude goes down a lot, although the peak time kind of stays the same. So I think there are some limitations, and it's important to kind of get some practice with it, get some normative data, but I think potentially it will be something useful in clinic, maybe as a screening tool or something, just to give you a quick assessment of cone function. I don't see uveitis patients, but colleagues who do. We did a study where we looked at birdshot chorioretinopathy. Now that only affects Caucasians, so you probably don't have much in Saudi, but the 30 Hertz flicker ERG is very helpful to monitor their retinal function. And patients I see in another institution, not on Moorfields, they rarely get ERGs because you have to send them to Moorfields. It takes a few months. How are you going to decide what you're going to do at that moment for that patient? Whereas if you can do a quick flicker ERG, 30 Hertz flicker, within a couple of minutes in clinic, you can get an idea of what their flicker peak time is. So again, it can help, I think, in management of uveitis patients potentially. But there's a lot of work to do. People often thought it would be good for pediatric patients. I found that a bit hit and miss. You thought it would be, but because it still goes over the eye, I found some kids tolerate it and some kids won't tolerate it at all. Whereas the way that often ERGs are done in pediatric patients with a strobe that's at a distance is probably easier than trying to use the Retinal in some kids. But as you know, kids are different. 3-year-olds, some of them you can do the intraocular pressure and it's okay, and others you can't. So it's a bit variable. But people are using it in theatre for examinations under anaesthesia. It's a kind of nifty device that's not very big. So I think there are some limitations and probably a bit more work to be done, but I think it's potentially very useful. Sorry, that was a bit of a rambling.
Yeah, no, thank you very much. I mean, we're starving you practically, so we
oh no, it's all right.
So there is another question from one of the attendees, was about how does macula of retinal detachment after reattachment surgery affect the A and B wave? I think, I mean, they left it open whether scotopic or photopic. So what's your take about this?
Yeah, so I haven't done big studies in retinal detachments, but I think if the retina, it can be variable, and if the retina has you've lost a lot of retina. Even when it reattaches, often it looks kind of scarred, and you've lost quite a bit of retina. You can sometimes find the amplitudes are reduced, but the peak times are often not changed because the rest of the retina is working fine. I can't really say much more than that. If the macula's off, then and then when it's reattached, depending on how well that goes, the pattern ERG may be variably affected. And then there's a whole literature looking at, for example, silicone oil-related visual loss, where you lose ganglion cells or the nerve fiber layer. That can have effects in the pattern ERG. People have also looked at different dyes used during retinal detachment surgery or vitrectomies, and find that some of them cause changes in the multifocal ERG. But I'm not really an expert on ERGs after retinal detachments. I don't know much more than that.
Thank you very much. I think there is a question from one of the attendees. I will just try to answer it quickly, because it's about, among electrophysiology testing machines, which one is good for flash and full field ERG and multifocal ERG. I think we have a financial disclaimer here, so I don't think that we are supposed to answer this live. But I think, I mean, if you're happy, we can share your contact details, correspondence, and this person can get the information directly. Another question is by Dr. Marwan Abu Ammo, who is a full professor at King Saud University in vitretinal surgery. So obviously he's got a vested interest in multiple issues in retinal disease. And his question was, can you tell us more about your paper looking into phenotypic and genotypic correlation between myopia and intelligence?
Right, yes. So that's interesting, and you can also, I'm happy for you to email me, and I can put you in touch with the first author on that paper, who will be able to answer it much better than I can. But basically, there is a correlation we know between myopia and intelligence. So apologies to any non-myopes there. There is a correlation, there's no doubt. And people don't know whether this is environmental exposure, whether it's kind of related to, those are the kids who read lots when they were young, and therefore they're more intelligent. And so it's very hard with many traits that are associated to tease out, is this an environmental kind of confounding effect, or is there a genetic correlation? And it seems to be, you can look at genetics and shared polymorphisms that are associated with intelligence and with myopia, and you can get an idea of actually there is a genetic correlation. I'm not saying the environmental stuff isn't important as well. There may well be, and we know myopia is very heritable, and even that's confounded because you could have more intelligent parents kind of making their kids study more or something like that. So even that, you don't know how much is genetic and how much is environmental, but there definitely is a component of genetic correlation and association between myopia and intelligence. So there are shared genetic loci. So it seems to be partly, I'm not saying all, but partly, maybe minority, I don't know, but partly it's genetic, as well as maybe there are some environmental factors as well. But if you want something more, it's a while since I even thought about that paper, but if you want some more details, then I can definitely put you in touch with the first author, Katie Williams.
Thank you very much. Back to the surgical questions again. I told you we are a breed of surgeons after all. Dr. Sausan Noilati is asking about how does the ILM peeling in the macula affect the multifocal ERG?
Right, so I don't have direct experience of that, but I have been at conferences where that sort of data was presented. And I don't remember. I remember there was something about dyes and different dyes. So the dyes that we know can have some toxicity, they also affect the multifocal ERG. But I think people have looked at the ILM peeling and looked at multifocal ERG itself, not just looking at different dyes. But I'm not aware of kind of more of a full field ERG, man. Can you believe there are ERG subgroups? So I can't say much more than that. Sorry.
Dr. Noilati again is asking this question. I mean, she's the Saudi expert in posterior microphthalmos, and I learned about posterior microphthalmos actually when I was her fellow before I even traveled to London and learned about MFRP and so on. Yes. So she's asking whether the amplitudes of ERG are higher in hypermetropes, and she put between parentheses, I noticed this in posterior microphthalmos patients.
Oh, that's interesting. So yeah, I can't say I know much, although our patients must have had ERGs, and I can't really remember what the findings were. But generally speaking, say in the healthy population and looking at hypermetropes and myopes, you're right, the myopes tend to have lower amplitude ERGs, although the peak times are said to be similar, but often the amplitude is down. So high myopes often have lower amplitude ERGs. So comparing hypermetropes with normals, I haven't been aware that hypermetropes particularly have higher amplitude ERGs. I'm not aware of that. It might be the case, but definitely high myopes, we do see lower amplitude ERGs, both full field ERGs and even the pattern ERGs in those patients seem to be of lower amplitude, and people have speculated about scleral conductance or the shape of the eye and the vectors of the components of the ERG as to why those amplitudes are lower.
So I mean, that's quite interesting, because when you mentioned the position of the skin electrode, and you said if you actually pull it slightly away from the eyelid margin, the amplitude drops. And one would think simplistically that if in a shorter axial length, actually, if you bring the retina closer to the cornea, you might be able to actually pick up higher signal. What do you think about that?
Yeah, I think that's possible. Yeah, I think I mean, we don't know, but there is this relation with axial length, and it could well be that. It could be just the position of the retina. It's complicated as the retina's it's a globe. So you could also think about it as because myopes often don't just have bigger eyes; they're sort of elongated, kind of oval. So is it the case that the superior bits cancel out the inferior bits because they'll be opposite polarities, and then you're only getting the bit at the end, whereas in a more globular eye, it'd be different. This is all speculation. I don't know, but I think it's a good point, Rula, that whether it's just a position related to the axial length, position of the retina relative to the electrode or the posterior pole, maybe, I don't know.
And last but not least, a question from Inam Danish. What's the earliest age you think it's useful to perform an ERG test, and do you use sedation for kids?
So I have to say, I personally don't see kids, and all of my research is with adults. So I'm not the best person to ask about kids, but I can put you in touch with kind of a pediatric electrophysiologist. And as Roland knows, I don't do clinical electrophysiology so much, apart from we look at the waveforms with our electrophysiologist colleagues. I mainly do look at the research side of things and kind of look at novel protocols. In kids, I think you can do ERGs at any age, potentially. It's just a question of, so I know at Moorfields they rarely sedate the kids because they often able to, if you have often they have two technicians rather than one, so one can distract the child and with the help of the parent, and often you can get usually with skin electrodes rather than with a corneal electrode, you can get decent ERGs even from very young children. I don't know of any kind of cutoffs in terms of age, and I know people certainly in a research setting have done ERGs in very, very young infants, so it's always possible, and it's something that's often added as an examination under anesthesia. It also raises the question that, as what we don't know much about because there's not much normal data, is in the first few years of life, is your ERG what we think of as normal in the adult probably isn't the right thing to compare with when we're looking at children's ERGs. So I forget her name now.
Eva Lenassi and Marco Paulino?
Yeah, I was thinking Anne Fulton, and I think
Anne Fulton, yeah.
have done. Yeah, so a few people have done ERGs in very young infants and found that the shape of the A wave is different. And John Robson was telling me he thinks that even the nose might not be present, which is interesting because it might tell us something about the development of the retina.
Well, I mean, as you know, that the fovea continues to develop until the age of approximately 4 years. So I think like pruning and maturation of the retinal, wiring might still happen actually postnatally. So that's not impossible. I know that there are certain labs like what you mentioned, Ann Fulton and the lab in Toronto also, they do have already like fixed, examination under anesthesia protocols where they kind of try to pick the type of general anesthetic that it has the least effect, but nevertheless, you never know how much it affects the ERG, but at least it can give you a ballpark about what's happening in the retina in case, push comes to shove and you really need to investigate the child. Dr. Omar Mahru, on behalf of everybody and on behalf of myself, thank you ever so much for accepting our invitation. We've been honored to have you on board virtually and at KCASH here, and we look forward to a very fruitful collaboration, inshallah, in the future between our institution and yourself.
Thank you very much. Thanks for inviting me, and wish you all a blessed Ramadan as well.
Thank you.
Thank you so much, and yeah, and we'll see you soon.
Thanks.
Bye.